So my intent, obviously, to discuss with you the issue of memory and aging. And one of the interesting things about this topic that I usually talk about this with clinicians and trainees in medicine, and which is obviously I'm intending to cover some of that. But at the same time, when the audience widens to different audience that's interested from a different angle, including caregivers, perhaps patients who are dealing with early memory impairment, I had to reflect and say, well, what is it that this audience want to hear? Is it the dry clinical data, or is it actually looking at the interface between normal aging and where does things kind of become a little bit more confusing? Is this a normal process? Is it a pathological process? So I'm going to try my best to go over what do you expect to see in normal aging. And the intent of this talk is to walk through some of these steps. It's really something helps me kind of organize my thoughts around it. So what is cognitive function? What do we mean by that? What are the elements that we look at in cognitive neuropsychiatry? And what is cognitive aging? What would you expect to see when people get older? I mean, we know that every part of our body changes with aging. And we know that, obviously, our skin changes and wrinkles increase, the hair become white, tongue gets smaller. There's a lot of details out there in gerontology to tell us what ages, but the brain also ages. And some of the changes that we have to look at is the outcome of that aging of the brain, which is the cognitive changes. The other thing I wanted to cover, what are some of the cognitive disorders that we see in old age? So as a clinician in that area and as an educator in that area, I want to share with you what do I see in my clinics and how do I classify these illnesses. And of course, I'm not going to be too technical about it, but I want to make sure that you hear some of the names and the diagnoses, and I'm going to leave it up to you to tell me what else you want to know about it. So I'm going to give an overview. And then if we encounter a cognitive disorder that is kind of diagnosable, what is the normal course of assessment and treatment in our clinic? So it gives you a snapshot of what is it like to practice as a cognitive neuropsychiatrist. What do I see and how do I make my decisions? And of course, you will let me know from your questions, from your discussion points, if this is what you want to hear, or I mean, I can modify my presentation to meet your needs, because that's really the key element here. So during this presentation, I'm happy to pause now and then, like after I finish one aspect, to get at least your perspective, one or two questions, so that we keep track of time too, but at the same time allow you to engage in this process, right? So I'm going to start with the cognitive function. What is cognitive function? So when I look at a person in any setting, including clinical setting, I'm wondering if they're alert and awake. Are they here with me? Because alertness is something that affects the whole assessment process. So we know it from a condition called delirium that I'm going to mention later, that people kind of fade away as you're trying to assess them. And it's frustrating for you. You think that they're not trying, but it's actually part of the illness. At the same time, I see it in my audience sometimes. They fade away because I'm not interesting enough. And if you're not awake, obviously, you're not going to receive what I'm going to say. So the first thing to assess, basically, is this person awake? Are you going to be able to engage in an assessment? The other aspect is language, because most of the testing that we do is quite verbal. And this is a limitation. I don't think it should be the rule, but it is what we ended up inheriting from years and years of cognitive neuroscience, is that we developed a lot of assessment tools that rely on language. And what that means, basically, that I have to make sure that the person is understanding me, have good receptive language, and at the same time, are they able to express themselves? And I can give you one interesting anecdote of a person that I was assessing who comes from the UK. And the assumption was, from the referral source, that this person scored very low on a screening tool called the MMSC, the Mini-Mental Status Exam, and that this person had a dementia. And as I'm assessing him, I kind of went with that assumption because the score was very low. And I'm talking to the family member, his son in this case. And then I noticed, though, that the person is very engaged in the process and nodding whenever wanted to say something. And I couldn't ignore it anymore because I see that this person is really... So I looked at the record again, and I found that this person had a stroke a few years ago that affected his expressive language. So I turned to the son and said, well, your dad has a stroke. Did he have a problem with his language when he had a stroke? He said, yeah. And from the minute he had that stroke, he couldn't really express himself. And then it occurred to me that, well, let me see if this person knows. So when you start giving him choices and get him to write things, for what did you want to tell me, this or this or this, he was able to engage fully. So his score would have gone much higher because now I gave him the tool to express himself and tell me how much he's with it. So if I tested this person using visual memory things or things that do not rely on verbal output, he would do very well. So this is a lesson that I learned, and that led me to put language and alertness as two caveats that I have to keep in mind before even going any further in assessing people. And then we go to the usual breakdown of memory, which is what we all hear at memory clinics, memory disorders, which is kind of the core component of Alzheimer's disease. And the reason why it became central to the whole field is that Alzheimer's disease is an illness that starts with memory impairment. So it is a very important aspect. But there's also other aspect that we look at, executive function. And I can give you today's example. I arrived at the wrong site. Now I needed to make a lot of quick decisions, contact the right people. So I contacted Manny, of course, because I thought that he would be here. He's the one who organized it. He quickly told me where I should be, gave me a map. So all that is happening. Now, if you're disadvantaged in the ability to plan and sequence, you'll have problem with executive function. That's what I mean. Executive function is quite a broad thing, but I think the very basic details of it is the ability to put set of steps that leads you to where you want to be. So I was in the other side there, in the medical science building, and I need to be here. Should I take a taxi? But first I need to know where are you guys sitting. So all that happened very quickly with the help of my good aide here, Manny, who gave me actually the tool to get here. There's visual, spatial, and sensory issues. The people with these illnesses, sometimes they don't know where to go. So it's here, it's not about remembering. It's not about remembering, well, there's a sign there that says this. That's memory. It's more being able to place yourself in space. Where do I belong in space? How do I get from this point to this point? Like imagine, it's more of a sensory issue. And the last part, what we call praxis, which is really the programmed movement. So basically, things that you've learned to do. So I get dressed. I don't think anymore about what do I need to do to get dressed. But you can, if you go trace back to how we learned to get dressed, how we learned to button the shirt, those movements were not automatic in the beginning. We learned them. But after they become automatic, that's that. So then there's something that we call dressing apraxia, where the person loses the ability to dress themselves because that particular program is now not available. So you see how it is a broad spectrum of things that we assess. So this is just to give you a flavor what's cognitive function. And the one thing I wanted to point out that all these issues, being alert, memory, spatial, language, all that other stuff, really what leads you to function day to day. So which is why when we assess people that complain that, well, my memory is not as good as it used to be, we always ask, well, what happened to your function then? Is it affecting your function in any way? And there's a huge set of challenges there because a person who was able to do up here for a level of function, they may drop down up to here that is still higher than my function, right? So it's important to know where is the baseline of the person. So function become an important question, and what tools do you use to assess function, what kind of questions you ask. So I covered now just very quickly what are the cognitive questions, what are some of the cognitive domains that we test. Anything that comes out of that so far, was it clear enough? Did you guys feel I covered at least a good overview of it? So then we can move on to cognitive aging. So these are the challenges that we face as we get older. Now, this is a graph that tells you what happens. I mean, when we start in childhood, we are acquiring cognitive skills, and we continue to acquire. And of course, mid-20s is really the time when you have finished acquiring your cognitive skills. So some of the young college students are here. They know you're not there yet. You still make decisions that you may regret later. But after that, there'll be a steady decline. Now, it's going to be very flat in the beginning, a bit of plateau and then flat. But by mid-50s, we start seeing faster decline in cognitive function. Now, I want to make sure you know what is changing. It's not the pathological change that we're talking about here. This is the normal change. This is what you expect to see. And what really changes is speed of processing and cognitive efficiency. Basically, how much you can process in one given point of time. And you know it. I mean, if you are in this age group, you know that don't tell me too many things. Give me one thing at a time. I can think about it. I can integrate it. You have a good conceptual framework. You can integrate the information to your framework. but you don't want everything to happen at once, right? So cognitive efficiency become an issue. And of course, because of the change in cognitive efficiency, basically a lot of the other cognitive domains could be affected, which is why we have to keep in mind when we test people that they have to be compared to their age match. You can't compare somebody in their 20s to somebody in their 50s and expect them to have the same scores. Maybe a person in their 60s may score better on certain things than the 20s, the conceptual issues, the issue of language and being able to articulate. So there are things that I'm going to show you that are well preserved with age. But the memory, like if I give you, okay, I want you to remember 10 things right now, and then I quickly want you to repeat it. I mean, you may say, look, slow down. I mean, I need to integrate that information one thing at a time, and then I can remember. So it's not that I don't have the ability to remember, but you're just bombarding me with a list, and you expect me to pick it up like this. I don't do this anymore in my 60s, right? So it's important to keep in mind those caveats. So I'm going to walk through some of the expected changes with age. So perception change with age. We know that we don't hear as well, we don't smell as well, we don't taste as well. Things change with age. Now, this is a relative change. It's not like you're going to lose everything, but it's just, that people have to talk to you slower, not too many people talking at the same time. What that translates to, though, that you're going to be at disadvantage if you're tested in a noisy environment, for example. Right? Or somebody, a very shy trainee asking you questions and you can't even hear them. At one point you're going to give up because if you're not getting the input, you're not going to be able to remember. So we keep that in mind and we try to teach our students, tune to the sensory deficit. Make sure the person have their hearing aids if they need one, the glasses if they need one. The other issue that changes, this is more cognitive. This is moving toward attention. So one thing I pointed out here, that alertness is qualitatively different with age. So when studies have compared younger groups to older groups, senior groups, when it comes to what time of the day you test them makes a difference. So most of us seem to move toward morning as being better time for us, which is why my mentors email me 6 in the morning and then becomes 5 in the morning. They wake up early and they're so active at that time. Now later in the afternoon, people start slowing down with age. So, and I'm not talking about old. I'm talking about the age 30 and on. You start seeing that difference. You start preferring morning. Keep in mind, there are some individuals that behave differently. We're talking about overall, like average. The other thing that changes with age is the ability to shift attention. So you probably, at any age, you'll be tuning to something and focusing on it, and that's your way of drawing your attention to something important in your environment. So I don't think this changes with age. The ability to select something and stay on track, you can do that. But the minute you get distracted with too many things, if you get older, it becomes problematic, right? While younger kids, they're doing everything at the same time. They're texting, they're driving, they're reading their book, they're doing it, and they can do that. They can afford doing that. We can't. I lump myself in this. I'm now in my 40s, so I know I'm preparing for that. So I no longer can do what I was able to do in my 20s because of that. The other issue is working memory. Now, working memory, the ability to actually maintain digits, or what they call chunks of information. So 7 chunks of information plus minus 2. The classic example is the phone number, obviously. It seemed to be designed for that purpose. That number seemed to make sense, right? But then if you ask the person to repeat the number backward, with age, we have difficulty doing that. And that's probably because of that point before, which is the ability to shift, go back and forth. Am I supposed to do, so we give people 4 digits and tell them repeat them forward, they're fine. As we start asking them to repeat backward, it becomes more problematic because they can't keep it in mind while they're dragging the other number that's supposed to come next. So it's important to keep that in mind. Now, I'm going to spend a little bit of time on memory. So memory is a term that we use for everything sometimes. So when a person comes and say, well, my memory is not good, I really spend enough time trying to understand what part of memory difficulties they're having. So memory, the most common thing that we talk about in memory clinics is episodic memory. Saying that I remember being here and now, for example. I can probably, a few days later, I can say, yeah, I remember that episode. I came here. I was in that particular building. There were some people around. So that's an episode that I can relate to. I have the context for. And to be able to make episodic memory, you need to encode the information. So encoding meaning that I need to integrate from this whole experience as much as possible so that I can make an episode of memory. It's a file that I need to integrate. So I'm going to probably integrate the color of the room, the smell, the lighting, people that I see. And I think that changes with age. So for example, I'm going to give you an example. I parked my car where there was a pizza restaurant. Now, if you are struggling to keep something in mind because you have to go and meet somebody and you're in a rush, you're less likely to be able to integrate that information as you get older. Like the ability to say, okay, I parked here, there's something. So you put a lot of information in mind so that you go and do your meeting and come back and be able to find your car. So when people say, oh, I didn't know where I parked my car, I'm not as concerned as long as I know that, well, the person was in a rush, it's not something that's happening repeatedly, so there will be some episodes that you're not going to find your car, and that's okay, as long as we know where it's coming from. If it is a cognitive efficiency issue, the inability to integrate information. Now, this is the part that gets affected in Alzheimer's disease, which is you actually encoded the information. You put the information in mind, and now you're supposed to keep it and make a file. And the file in the brain is usually a network, building some connections. So that is the problem that affects people with Alzheimer's disease, because the hippocampus is the area of the brain that make those connections, make those consolidations and filings. So that should be normal in people who don't have Alzheimer's disease. When it becomes a problem, then we start thinking about Alzheimer's disease. The other issue that we see a lot of actually with normal aging is now that you have encoded the information and stored it, well, what happened when you need it? Like, how can you bring it back as fast as you want to? And that may be a problem with aging, because you may find yourself blocking on it, and now you have to know that it's not abnormal until it becomes really problematic repeatedly and affect your function, because as I mentioned earlier, the cognitive resources are limited, so you might be having problem to encode to start with. So when somebody tells you, hey, where did you go last? You told me that you went somewhere. Well, if I didn't really spend enough time associating the information with a lot of details, encoding it, I may not have easy time retrieving it. So retrieval is dependent on encoding, and both of them can be affected by normal aging. Now, long-term memory, this is continuing with the same theme, could be also semantic instead of being episodic. So this is when you say, I know that Canada is north of the United States. This is a fact. And with age, these things get better because you build more and more information, more and more concepts. That's why, as a parent or grandparent, your grandkids love to listen to you because you have a lot of information to tell them, because you know a lot, right? So, and sometimes that's something I use to help people know, even if they're dealing with Alzheimer's disease in the very early stages, that you have not lost everything. You still have a lot of information that you can engage, people that love you and tell them stories. So semantic memory is not something that we see impaired early on in Alzheimer's disease, but also should be even better with age. I wanted to also point out that autobiographic memory, which means that something related to me. One thing I wanted to highlight, that emotional salience, like if something has something to do with positive experience or sometimes even fearful experience, it's more likely to be remembered. So that's why sometimes the family members will say, well, but my dad can remember this. Well, yeah, because that event was very important. It really was a rewarding thing. Like his grandson came and they had a good time. They may remember that because it's a positive experience. So it's keep in mind that putting fun, I guess, in things may make you remember them better. Now, procedural memory, how to do things, usually preserved in normal aging. Implicit memory, meaning that things that are unconsciously get associated in your mind. For example, watching TV, eating a slice of pizza. You're conditioned to do that. Every time you sit to watch TV, you think about pizza, for example. That's an example of something conditional. These things happen. They're happening without your awareness. And now, the issue in terms of forward thinking about things later, what's going to happen later, I think one thing that I give people advice is to try to make sure that it's structured, it's predictable. Don't rely too much on yourself remembering at the spot. So, moving forward, I guess, is a bit more challenging because you need to make sure that you have enough cues to keep you on track as you get older. Language typically is preserved, especially the expressive language. Of course, receptive language, if you can't hear something, you may not be able to understand it. And the same with working memory issue. But decision-making typically is intact. The only thing is that the cognitive neuroscientists pointed out that decision-making is a little different. Typically, people who are in their senior years, they rely on experience, and they seem to trust experts more than younger people. So a younger person want to figure it out. They have no, they look at it themselves, they search it on the web. We tend to see that seniors, you say, well, so-and-so seems to know what they want, what they're doing, so I'm going to trust them. And which kind of raises the question of financial abuse sometimes. A neighbor that was an accountant giving you advice. So we always keep an eye on this because we don't want people to be taken advantage of. So, people in their senior years make good decisions, but because of the limited resources, sometimes they rely on other people, especially experts. Now, why do cognitive function change with age? Well, we do see some what looks like Alzheimer pathology. So the Alzheimer pathology, the amyloid and tangles, these are things that you see, and you'll see it at the end of this talk. Minor components of it happens in normal aging without Alzheimer's disease. So that might be a reason. We seem to lose synapses, which are the connection between neurons, and we even lose neurons with aging. Some neurochemical input, like some of the chemicals that keeps you alert and active, could go down with age. And there's some even loss of volume. So we all know, radiologists always say, well, this brain is shrunk, but it's normal for aging. So we know that there's something called normal. But there's no actual cell death or inflammation or something that indicates there's a pathology. That we don't see. So this is just an example of how a young brain would look. And now if I look at this brain, I may say it's normal if somebody's in their 90s. That's an okay brain. But if you actually want to compare them to this, you can see the difference between the ventricles here. So certainly there's a loss of volume, but that's still a normal person functioning at their age and education match. Now, to kind of bring it towards the interface between normal and abnormal, so all what I described is what we call the benign change that's expected with age, which is the hallmark of it is cognitive efficiency, not being as efficient in being able to process information. Now, sometimes we see people who are concerned about their memory, but you still cannot find anything with testing. We find a tough time, and we actually finally tell them, okay, well, it's a subjective memory impairment. Let's see what happens. We have to wait and see. And we give them advice how to compensate, how to stay healthy. And this is where we become a little bit more concerned, where the person is concerned or their families are concerned. And then when we test them with high-level testing, this is not the usual bedside testing. Usually this is like a neuropsychologist, or we use high intensity kind of battery of testing. We find something there compared to age and education match. And that's when we start thinking, well, this might be a transitional zone towards an illness. So there has been a lot of interest in this. I'm going to talk about it. So there's a global deterioration scale was published in 1982 by Reisberg. And the group that I'm referring to here, the malignant, are those who are with intensive assessment by an expert. You can see some impairment, loss in unfamiliar places, poor work performance, name-finding problem, loses valuable things. So you start seeing some things that are repeated and indicate that there's some struggle underneath. And one of the things that we're seeing also that people who function at a much higher level, they complain more. And some personality styles too, like those who are driven to be exact and they like things to be done on time, they start struggling more. And that's the group that we call subjective memory impairment. But if we see something with testing, then we have to start thinking about where are we in the spectrum. So this is what I call the cognitive continuum, that normal is what I described for age. This is the mild cognitive impairment, MCI, is the transitional zone that we have a concern because the person is scoring below what's expected, and this group is at risk of developing dementia. And I'll show you what this group looks like. This whole thing is just to break it down to, there's a group that we call amnestic MCI. So they have some memory complaint, and when you test them, they are impaired for age and memory. It's only memory here. Here it's memory plus, and here's some other cognitive domains. Now these people score one standard deviation. Now standard deviation is statistical marker. So the mean is here, one standard deviation on both sides of the mean. It could be superior, it could be inferior. So we're talking about a person who's scoring reliably below the mean. And these days, actually, we're using 1.5 standard deviation because we didn't want to include too many people. We wanted to make sure that we're very specific. Somebody's concerned, and we're concerned about them. So I think we use now 1.5 standard deviation just to make sure that we're well within that area. Now, I'm not going to bother you with this. It's a structured interview that they score 0.5 on. But all these patients that score 1.5 standard deviation below the mean seem to progress to Alzheimer's disease at about 12 to 15% per year. So roughly, if you just take a normal population, 1 to 2% will show Alzheimer's disease per year. But if you have somebody identified as having MCI, you have a clear concern, and you're detecting it, then the risk is almost 10 times more. So it is a risk state, and we wanted to find out, could we do something about it? And that's what all these studies are being conducted to see, could we modify this? So I think I've covered so far cognitive aging, and the MCI, which is the mild cognitive impairment, the risk state for Alzheimer's disease. It's not yet a disease. It's an entity that we consider clinical because we have something to go by, and there's a lot of interest in understanding, could we actually stop it from converting to Alzheimer's disease? So all the research that's being done now is, of course, helping these people with compensation strategies, but help them stay well, which is really the point. Could you actually prevent this person from developing Alzheimer's disease? And that's the motivation behind identifying. So any burning questions so far about the concept of MCI or cognitive aging? Comfortable? All right, well, we'll move on then. So now I'm going to move to the clinic now. This is where we're talking about a cognitive disorder. So I'm going to show you now this is a bit of history. Anybody recognize this person or have seen this picture before? So this is Auguste D. She's the first person diagnosed with Alzheimer's disease by Alzheimer himself, by Alzheimer. And she was in her 50s, 51, 52. So Alzheimer's disease was always thought to be a neurological disease that hits younger people, relatively younger people. It wasn't, senility was not the issue with Alzheimer's disease. It was only those cases that show up at that age that were considered Alzheimer. But of course, we started getting older and older, and that's when we start seeing the second wave of Alzheimer, which comes in late life. So obviously, all these people, Churchill developed some kind of dementia. It's probably more vascular, because he had several white matter changes in his brain, some stroke-like. Now, Thatcher had Alzheimer, these two, Reagan, who probably created a lot of funding for Alzheimer research, the Reagan Foundation and all that stuff. And now, this is one of my heroes. Do you know this guy? Yeah, Gabriel Garcia Marquez is a Nobel Prize winner in literature, just diagnosed this last year having Alzheimer's disease. It's one of those, like when you see your people that you read and enjoyed and the literature, and so it really hits anybody. It's important to keep that in mind, that we're dealing with a public health problem that hits people at any. Doesn't have a social class. Go ahead.
You talk about Alzheimer's and dementia.
Right. No, but a good question. I want to clear that out because I think the question whether, and that question comes up in the clinic. Alzheimer is dementia. Dementia is the term that we use to indicate loss of cognitive function that is acquired in late life. Alzheimer is the most common cause of it. And you'll see the pie, like the distribution, the statistics. So Alzheimer is just the most common type of dementia. Right? But dementia could be a person could have head injury and have a dementia because they now have very similar pictures. So we have to, now when we see somebody who presents with cognitive impairment, we typically want to make sure that we don't miss acute change that could be reversible. Like somebody who ended up delirious, which is something that can happen to any of us. Anybody who sustained a surgery, for example, and they were bombarded with all kind of narcotics to keep them from having pain, but at the same time they got dehydrated, they may get delirious at any age. And of course, older adults have more risk of falling into delirium because they have less cognitive reserve, less chemicals actually that fuel attention. So I've seen delirium in all age groups. You see it a lot in alcohol withdrawal, for example, and that's a delirium and could hit anybody, right? So delirium is something we want to know about because we want first to see if we can treat the underlying cause and also prevent it from being called dementia, because a person could be placed in a long-term care facility in a state of delirium and then they improve there, and all of a sudden, what am I doing here? I'm still okay. I can still function home. And once you get to that system, I mean, it's hard to get there, but if you're lucky, I guess, from a general hospital and they place you, people think, no, don't lose this bed, because now the other problem is that people with delirium can end up showing the first sign of dementia too. So you have to always decide what is the actual baseline after you treat the delirium, where did this person land? So delirium basically is an acute change. So this happens over a few days, really not a long, steady state. Something just happened. Well, my dad or my mom last week was okay. Something happened. So I need then to alert myself that this could be delirium. And it tends to fluctuate. Evenings are very bad, morning okay, the person in and out of alertness, they're disorganized, and the level of consciousness. So this is a method that we use to assess delirium. And it is a very big problem. I mean, in general hospital, we see a lot of delirium. So people who consult in the general hospital get consulted, like neuropsychiatrists and psychiatrists in the general hospital, see a lot of delirium post-surgery, after hip fractures, and tend to make things worse, basically. Longer stay in the hospital and more risk of dying, actually, if you have delirium in a hospitalization. So it's really a serious issue. And what happened to delirium when it clears, now, as I said, sometimes people stay longer in the hospital, but also could be placed in a long-term care because they're still not functioning. You think that's going to be it. And it could be a marker of future cognitive decline. So those who recovered from delirium, 20% will develop dementia. It's even higher than MCI. So you can tell that now it could be just because it's a signal of the brain struggling to start with, and there's something added to it. For example, somebody who is lingering at the edge of normal, they go for a surgery, they show delirium, then it was the signal of the cognitive impairment. Now, when you talk about dementia, though, here we're talking about a person who had a change from a higher baseline function. So you say 6 months ago, so-and-so was relatively okay, was able to remember most of the things, and now they have problem with memory, plus either language, motor function, not finding their way around, not being able to plan. So usually we take memory plus to be able to say at least 2 higher cognitive functions has changed from baseline. And that this change is really affecting social and occupational function. It's not just, I'm concerned about it, I can still do everything else. Here we have, because that's the difference between this and the mild cognitive impairment. Mild cognitive impairment, the assumption there that the person is still relatively okay functionally. They can still do things. They're not impaired. They can still drive. They can still. If they have any impairment, it would be in a very high level functioning. So it's an important aspect to consider. So decline in function. And we also have to make sure it's not due to medical conditions or substances. It's not delirium, because if somebody was just given a prescription to make their bladder better, but goes to the brain and confuse them, there are some bladder medications that make people more confused. Or somebody have been drinking and all of a sudden they stop drinking because they were admitted to the hospital, they go through withdrawal from alcohol. So there's a lot of things we have to keep in mind. And of course, not due to psychiatric illness, because depression in a severe form could look like dementia. A person cannot think. Their mind is not working. So you have to treat that. Schizophrenia, for example, people with psychosis, they may not be able to be tested because they are preoccupied with something in their mind. They're not online with you. They can't even participate in testing. So we always rule out all these factors before we consider this as a dementia syndrome. And dementia in general is something that has cognitive, neurological, and psychiatric symptoms. At least that's what we look for. Now, Alzheimer's disease, typically cognitive in the very early stage, meaning memory, not finding your way around, word finding problem. But a lot of times we see psychiatric symptoms. We see anxiety, depression in the early stages. As the disease progresses, you may see hallucinations, see delusions of theft, somebody taking things from me. So it's almost never that somebody will go through Alzheimer's disease or dementia without having psychiatric symptoms. It's very common, 75, 90%. And it's bad news. When a person is depressed and have dementia, they do much worse. Now, the neurological aspect, the reason why we tune to it, because it helps us to distinguish between different syndromes. So this is the cognitive issues. Now, these are the things that we see. So if we see somebody with Alzheimer's disease, which is a type of dementia, as I mentioned earlier, forgetful, still functioning okay, walk around, cannot do the financing anymore, cannot drive anymore, but they're still not falling, they don't have any tremor, there's no particular neurological finding. Now, if I find that this person that I thought has Alzheimer now have a tremor in one side of the body, I'm like, oh, I missed something here. This is Parkinsonism in somebody with Alzheimer's, so it could be something called Lewy body disease, Lewy body dementia. Or somebody has been thought to have a dementia of some sort, but then I noticed that they're not able to look up and down. And oh, this is different. That's not what happens with Alzheimer. It could be something called PSP. It's a progressive supranuclear palsy. It's a form of dementia. So all these things are things that we look for. The other thing that we look for is signs of stroke. So somebody have cognitive impairment, you think they might have Alzheimer, but then you find out that they actually have evidence that they've had a stroke. Maybe nobody noticed it, and you do an image and you find out on the brain image that they did have indeed a stroke. These are the psychiatric symptoms. Anything really go in dementia. Every single psychiatric symptoms could show up in dementia, which is why the field of dementia is really shared by geriatric medicine, cognitive neurology, and psychiatry, because we have to be part of it, geriatric psychiatry specifically, because we learn more and more about the brain, so that when we see psychiatric symptoms, we can make a distinction between the origin of it being psychiatric or neurological. And this is just to answer the questions that dementia is the big term that involves neurodegenerative illness, which has the progressive loss of like Alzheimer's disease, Lewy body, frontotemporal dementia, or could be because the person had an insult on the brain, such as a stroke, a brain injury, or substance-induced. Somebody drank repeatedly every day for a few years. Sometimes they end up in a syndrome that looks like dementia completely, but it is from alcohol there. It's more that the brain lost and permanently was damaged with this substance. And so when we look at dementia, we think that, well, what makes people develop dementia? We know that in Alzheimer's disease, age and gender seem to make a difference. Now, don't be alarmed. I mean, the signal that females have a little bit more than males in terms of Alzheimer's disease, initially it was thought because females live longer, but I think there's a bit of a genuine signal that maybe females are more predisposed to it. We're still debating it, but it's likely. Now, there's the genetic stuff that people ask about. You think, I have the genes for Alzheimer's disease. And the one thing I want to clarify that causative genes are the genes that if you have them, you're going to have Alzheimer's disease. Those are less than 5% of Alzheimer's patients. So it's not the more common form. The more common form, 50% have no genetic markers whatsoever. So if you develop Alzheimer's disease in late life, in 80s, most of the time, 50% at least, there's no genetic markers. But there is something called susceptibility gene, the ApoE4, which if you have it and you're going to develop Alzheimer's disease, it's going to happen earlier. So it's a bit of a, so we don't like to test people for this because we don't know what to tell them. Like if you have it, I don't know, it's still 50-50, I'm not sure, right? But then if you look at the groups of people that you test, you can detect that, yeah, it increases the risk by about 4 times. Right? So it's just a matter of being ethical about this. I don't think it's fair to tell people you're going to have a risk to convert to Alzheimer's disease for more than your peer, but we don't know if it's going to be you. Like it's just hard to, it doesn't have that power of helping people decide. I think those genes are much more likely to be. So if somebody had the presenilin 1, there's a few of them identified, that's almost 100% they will develop Alzheimer's disease. So when we see it in families, go ahead. Yeah.
Let's say a father has Alzheimer's, the daughter has Alzheimer's,
Mm-hmm.
the daughter's children, that's a hereditary thing, but is that genetic?
Yeah, so if you see several family members that developed this illness, especially if they developed this illness, as you said, several members within the earlier age group, then inherited usually through genes, right? Now, but those families are typically identified by the neurologist or whoever assessing them that, I'm seeing a cluster of cases in this family. So we typically send them to a genetic center to look at what we know, which is there's about 4 genes identified, presenilin 1 and 2, and there's one on chromosome 17. So we have few that are reliable genes. Now, if we see only one member of the family develop Alzheimer's in old age, like in their 80s, then it becomes diluted. It's not as significant of a signal, because families that develop several members in earlier stages, there's big suspicion there that they may have genetic cause for the illness, as opposed to, yeah, like everybody else, 1 out of 3 at the age of 85 may have Alzheimer, and half of them wouldn't have any genetic marker. So the signal become diluted as you develop the illness late in life. Does that make sense? Yeah, so being susceptible because you may have a marker, but as opposed to causative gene. And actually, the reason why this became important in the field, although it doesn't capture a lot of people, is that now with the disease-modifying therapies, like trying to actually interfere with the illness, we thought that this group will be the most helpful because we know they're destined to have it, so could we do anything to prevent it from happening? So although they may not end up being the same illness, they may have a bit of, they have the same pathology in the brain, but because they seem to behave differently, we don't think that they're exactly the same as the late onset Alzheimer's disease, but they have enough similarity that we think that maybe the therapeutics that work with them may work for Alzheimer's disease. Yeah, so we're still struggling in the field to find that answer to modify the illness, but that's just recently people started drawing attention to those who carry that gene. Yeah.
Could it be a case of that you might have a predisposition through genetics, but your environment acts on it or doesn't?
Yeah. Yeah, so I'll give you one specific example. So this is the question about the interaction between susceptibility genes and environment. So with causative genes, it's not easy to see that because people will develop Alzheimer's, whether they live perfect lifestyle or not. With the ApoE4, which is susceptibility. So this is, if a person have 2 copies of this gene and have head injury, their risk of developing Alzheimer's become much higher. Right? So that's an example of how the brain need to repair itself get impaired by carrying this gene. That's the theory behind it. We know that this ApoE is a gene that codes for apolipoprotein, which is part of the structure of the cell membrane, the nerve membrane. And if you cut a peripheral nerve, the level of that ApoE or the apolipoprotein goes up by 400 times. So we know it's a repair chemical. So if you carry this particular subtype, so most of us will carry one of these, either ApoE 2 or 3, or there's some subtypes that are okay. This phenotype, this 4, seems to be the one that does not repair the neurons well. So a head injury plus this makes it more likely. Now, I'll give you other examples, of course, that if you're drinking too much, if you're not exercising, if you're not eating well, all these things could, not having enough education, that's just another example. You might have grown up in an environment that did not give you enough enrichment and enough education. The first 8 years of life seem to be quite important in terms of building cognitive reserve. So we know that low level of education seem to make this illness more likely. So it's a lot of things that we have to keep in mind. And unfortunately, the more things we include in that formula, the less predictive power we have. Right? So lifestyle, physical activity, education, nutrition, all that stuff. And now I put sexual practices because we know that syphilis used to be a big problem, and now HIV becoming a big problem. Those are illnesses that could actually create a syndrome that looks like dementia as well, that affects cognitive function. So we have to screen for them, and that's part of the workup that we do. Medical morbidity like strokes, infections, head injury, all that stuff could actually increase the risk. So basically, from what I spoke to you about, that we do all kind of workup to find exactly what I mentioned to you. Try to kind of work up the person medically, psychiatrically, look at their blood work, make sure that they don't have anything that indicate delirium, like low sodium, thyroid function being abnormal, things of that sort. And then we do some testing. And the testing, I wouldn't bother you with it in more details. I just mentioned to you earlier that if the person is concerned, but also if their relatives are concerned, sometimes the person may not be as concerned. They may not see it as much, because if you're repeating questions, you probably genuinely want to know, again, what people told you a few minutes ago. But your family will be concerned. You say, well, I just told you this. Why are you asking again? Or you told me this story 3-4 times today. So we rely heavily on informants or family members because we feel that they have a good reliability in giving us. And then we do some testing. And those testings include things that we do in the office and also look at the functional quality of the person. Can the person still write checks? Can they still drive? That kind of thing. And we keep in mind the confounds of testing. So as I mentioned earlier, you test people, different age group, you're going to get different results. Education is important. Sensory deficits like glasses, hearing aids, all that stuff. And we test for substances and psychiatric issues, all the stuff that I needed to rule out to make the diagnosis, I need to think about, right? These are just some data from, you probably know by now that people, I'm just going to highlight a few, like 2 out of 10 after 65 will have Alzheimer's disease, 1 out of 3 after 85. So it increases with age, and that's, 1 out of 3 is a very big number when it comes to, we know that people are living to their late 80s now. And as I mentioned earlier, Alzheimer's disease is the bigger piece of the pie. So I know probably we're running out of time, right? Like what's the, what's
8:30, but we were a little bit late starting.
Okay, so I'm going to mention a few things about the management of dementia, because I think from the clinical side of things, you want to know what can we offer, right? Like if you actually know somebody who's diagnosed or have problem with this illness. So something I really emphasize with myself, of course, with my trainees, is that a person is biological being, psychological being, and a social being, and also live in a context. So you always want to, where am I seeing this person? So if I'm seeing the person in a nursing home setting, I have to keep in mind the factors that, that is included there. One is that this person is now dealing with too many people in their environment. The nursing staff could be alarmed by certain behaviors that I need to help. So basically, we try to understand what is the question and what is the context. A person coming to my clinic because they are just retired a year ago, and now they're really concerned about their memory. You start thinking, well, it seems to me that this person was busy, mind was occupied, now they have much more time to worry about this. So you have to keep the context in mind. And then when we build the management plan, one thing that I really have to emphasize is therapeutic alliance, because when a person comes to a clinic to find out that they have memory impairment, it has huge implications. One is that this doctor is going to report me to the Ministry of Transportation, and I'm not going to be driving again, which is a huge issue, because driving is such a fantastic thing, because you can move around, you can see your friend, so when you actually sit with somebody and say, okay, well, I want you to know that I really care about you, and you need to show it genuinely so that the person knows that when you're telling them about driving, you really have to. It's not like a choice that I'm making, and oh yeah, fine, you have Alzheimer's, I'm going to take your driver's license away. That's not how it is. We need to build good connections so that the person knows the risk and benefit of driving, and themselves will realize that if I drive, I'm putting too many people at risk. And sometimes we ask, the family members, if your daughter is pregnant, and you tell the spouse, would you let your wife drive with your daughter pregnant? And then sometimes family members say, no, he can drive or she can drive, but I don't want anybody in the car. So you know that there's a subjective feeling that this is becoming a risky process. So safety is an issue that we always have to start with. Driving, home safety, being able to cook, supervise, unsupervise, all these things. Fire is a big risk. How many times I can tell you, I hear somebody have been, how's your cooking? Well, it's fine. I burn a few things. And then you're like, well, you're living, with your family, and you're cooking in the middle of the night because you can't sleep, and you burn a few things. So the possibilities of everybody burning, it's just huge. So I can't, so that's when I have to sit with the family and say, I really want to address this issue. Please change that. Can cook fine under supervision, but not alone. And if you're alone, the stove has to be unplugged. And so there are some things that very, very like day-to-day practical things that we have to take care of. And the issue with capacity. So this is an issue that is quite confusing to people. Somebody has Alzheimer's disease, that doesn't mean that they lose capacity. They still can make decisions for their medical care, for their finances. But there are some situations where you reach a threshold where the person have been repeatedly taken advantage of, for example, financially, because they do not know how to keep track of money, paying bills or online shopping, or there's a lot of things that happen that put people at disadvantage. So that's where the financial capacity issue comes to play. So families will come to us and say, I'm concerned because my dad just emptied his account, and you find out that he gave to this charity and that charity. And of course, we see that in other illnesses, such as bipolar illness, mania. People become too excited about things. But here we're talking about somebody who forgot that they donated to this place, and they donate again, or they don't know how much money is left there in the account. So there's a lot of important logistics to take care of. Medical capacity, we try to the very last bit of caring for a person with Alzheimer's disease to include them in their decision making. The only thing is that we like to have somebody with them so that at least the person cannot remember the information, somebody will be around them to remind them of it. So you engage people in decision making. Now we do have situations where the person refuses to take treatment, not because they think that you're trying to poison them. Then you start thinking about capacity to make medical decisions now compromised because of the illness. So I've seen people who develop a delusion, and you have to take the capacity away so that you can treat them with something that they need. Abuse risk, as I mentioned earlier, financial abuse and then of course there's a set of interventions that we think about. So whenever we deal with a family that had a member with Alzheimer's disease or dementia, we really have to take care of the whole family because a caregiver, a spouse who's living with the person, they are the ones that suffer the most, and they're the ones that suffer the longest too, because you as a person could suffer some discomfort from not being able to remember, but as the illness progresses, you may lose insight and you no longer care about it. You're fine. It's people around you that care. It's the spouse and in fact, there's a huge literature on the level of depression and stress that happen in caregivers. So we really like to make sure that the family members, the spouse in particular, know that it's not just the patient that I care about here, it's you, and I'm going to work to try to get you the help. So through the Alzheimer's Society, sometimes respite care, there's the things that also the decision making about placement. People feel so guilty about that. They don't want to, you want your loved one to stay home to the end. And it breaks your heart to say, well, now I can't do it anymore. I'm not sleeping, and every night I have to make sure the doors are locked. And sometimes I find, my wife or my husband just wandering off the street in the middle of the winter. So it becomes a nightmare, and after a while, you just can't do it anymore. So to help the person make that decision, I need to say it's maybe time. If they don't hear it from the outside, they may not be able to do it. But I have to also encourage them to consider placement because it's probably time. Because I don't have the interest in putting people in nursing homes. We're running out of space everywhere, right? But when the time is right, when the person is now in need for it, we need to make that statement. Now, when we try to give treatment, I guess the classic kind of understanding of treatment in medicine, we think about risk factors. So could you do anything to help this person stay well? As I mentioned earlier, preventing stroke. So somebody have mild cognitive impairment. If they get a stroke, they're probably going to show much more impairment. Make sure that help them not be on medications that affect their mind. Staying active physically. All these are preventative measures. But then when we treat, we typically treat symptomatically. So meaning that you have a cognitive disorder, I'm going to try to treat that symptom. But also, you have a behavior that comes with that I'm going to treat. So you'll see that the treatment that we have available to us today are really symptomatic treatment to help the memory as much as we can and help the psychiatric symptoms such as depression and anxiety and psychosis. Now, the ones that we're still waiting for are the disease modifying. And there's a lot of trials. Unfortunately, there's still no big breakthrough there. The results have been still disappointing because when a person develops Alzheimer's disease, we don't seem to be able to bring them back. So we're still struggling with this. So, the non-pharmacological intervention we start with for the cognitive and behavioral symptoms are all things that are listed here. So try to help the person with support. There are some cognitive compensation strategies and problem solving that we try to help people with, especially in the early stages. Like if a person just have a bit of memory impairment, you may be able to help them stay well and compensate for that. The chemistry, our medication that we use symptomatically, I'm just going to show you two things. One is a class that we call acetylcholine esterase inhibitor. So this is where the chemical acetylcholine is released from one neuron, and this is the other neuron, and it's supposed to be broken down by an enzyme called acetylcholine esterase, and we prevent that from happening to make this chemical more available, right? So we're basically trying to that chemical that helps the person remember, keep it as much as possible available. So that means that we're not going to be able to stop the illness from progressing, but we at least boost that signal. You make that fuel more available by stopping it from broken down. So that's one class. This is what you probably heard about: Aricept, Axalon, Raminil, all these 3 agents that we have on the market. Still have them, we still treat people with them. What they really do is a modest improvement for about 2 years, 1 to 2 years. So a person may stay in place without progression, as opposed to like predictable decline. They may stay well a bit longer, right? So we have to be realistic that this doesn't mean that we're going to reverse the illness, stop the illness. And there is a group that do not respond. I mean, I have a third of people that doesn't seem to affect them. But I have seen people who stayed well for at least 2 years. And I've seen people who improved a little bit in their attention, their ability to participate. They're still forgetful. And that's why we still use them. They're quite reasonable. This is the other medication called memantine. And it's a complicated mechanism, but it basically regulates a chemical that's called glutamate. And that glutamate has to do with the excitability of neurons, like getting the neurons to fire. It's supposed to block that firing if it is too much. So it's just a modulator. It's not, we use it, add it to this. So we actually start somebody with one of these medications, and sometimes we add this medication. It's still, unfortunately, not funded in Ontario, and I think for a good, reasonable reason, because Ministry of Health, I think, looked at the data and said, well, we still don't see enough improvement to make it worthwhile paying for it. Now, in the States, in Europe, they prescribe it all the time. So, we wish that they would fund it because we don't have too many things to offer. So at least let's give people. So I sometimes tell people, if you want to take this medication, you have to pay for it, about $150, $200 a month. It's costly for some people who don't have much to live by. Now, behavioral symptoms of dementia, there's possibility that it is just to meet an unmet need. So somebody who doesn't have much cognitive activity left, they may just pace just to stay busy. So we don't call everything agitation. Like if somebody is just walking back and forth, it doesn't have to be called agitation. If the person is comfortable and just doing it for, to get their energy out, that's fine. But sometimes it's to communicate need. Such as, I don't remember, you told me I'm hungry, when's the meal time? And you go back, when is the meal time? And the nurse will be like, oh, you asked me this 1,000,000 times. So if you know where it's coming from, you may find some solutions such as writing and keep it on the nursing station that lunch in 10 minutes, lunch in 10 minutes. Or, so you can problem solve around it. Or it could be because the person have pain or discomfort. So a person who have Alzheimer's disease cannot express themselves and they're agitated, upset. Well, find out. Maybe they still have pain or they have some discomfort, like an infection in the bladder, or they might be depressed or anxious, or there's a lot. So we try first to find out what could be causing this agitation, and we try to treat it with some kind of non-pharmacological approach first. Try to avoid medications, finding out what triggers it, all these things like art therapy, music therapy, aromatherapy, all this stuff. Unfortunately, somebody is wildly psychotic, hallucinating, thinking that somebody's killing their family, we sometimes use these medications. As long as we keep in mind that maybe we can change the situation by correcting pain or correcting the environment a little bit. So we try our best to minimize the use of this medication. This is what Alzheimer's disease has. These are two pathologies, amyloid plaques and the tangles. And this is a normal brain. So the disease-modifying therapies, and this is going to look very complicated, but it's really about trying to prevent amyloid from aggregating, try to stabilize the tubes inside the neurons. So all these things are being studied as we speak. This is the amyloid, trying to kind of prevent one of the enzymes, try to stabilize the tubules. And so it's a very complicated thing. But I wanted to tell you that attempts are being made now to try to modify this illness. And unfortunately, we still don't have good news. There was actually some signal of good news at one point with the vaccination for amyloid. We had some success with it, and unfortunately, 6 people developed encephalitis and died. So that trial has to stop. But we were able to take amyloid out of the brain. And people who actually did not, I mean, the 6 out of, I think it was about 60 people or so, those who survived, a lot more survived than the 6, and they did well. But from that time on, we'll have to find something a bit more manageable, in terms of risk. So that's all what I know, and I shared with you.